thrilled to welcome our guest, Dr. Karen Lawford. She has worked as an Aboriginal midwife and registered midwife and is currently a professor within the Gender Studies Department at Queen's University. She conducts research regarding gender-inclusive sexual and reproductive health care for Indigenous peoples, with a particular focus on the provision of maternity care for reserve residents. She is also the 2020 recipient of the Inspired Laureate in Health for her research and policy work on mandatory birth evacuations.
Great question. So I do want to clarify that I'm not working as a midwife right now. I still keep my registration, but I'm actually not working as a midwife. But I was, when I was a young person and I had finished my first degree, I had a little boy, my precious son, and during my pregnancy, I had a variety of maternity care experiences. The first one I received was basically none at all, because at the time I was quite athletic and my cycles were very irregular. And it took about like almost 18 weeks, so well into my going into my second trimester, that I realized I was pregnant. So I would go to the doctor and like, I have so much acne, what's going on? And so they sent me to all these tests and assessments. And then I'm like, and I can't lose weight. Like, I was very small, but I was like, I can't lose weight. I run all the time. I do a ton of exercise. And they're like, we don't know. We'll send you for some metabolic disorder tests. And then my neighbor, bless her, she said, Karen, you're pregnant. I'm like, that's not possible because I just had a cycle. Like, it's really irregular, but I just had it. It turns out I had a miscarriage and my son is actually a twin. So it took my neighbor to tell me, like, the most obvious thing in the world, but because I was so athletic, I didn't, and the way my body is, I don't actually show until quite late. And I realized then that there's something going on. And so I went to see a family doctor who did deliveries. And I feel like she made fun of me. But I don't know that she would think about this. Of course, it was many, many, many years ago. But it didn't feel cool. And I'm like, I'm smart. Like, I just finished my degree in chemistry and environmental science. And I'm like, you don't get to talk to me that way. And so I don't know how I came to know about midwives, but I did find a midwife about halfway through my pregnancy. And that's when everything switched. Not just the length of appointments, but the actual model of care that I received allowed for communication, an exchange of information, and informed choice. And so I got to have purposely had a decision-making ability in my pregnancy to decide what was best for me. I was given information that I could think about and then come to a decision. Of course, knowing that sometimes there are situations where decisions are out of my hands. And of course, that's kind of like life or death type thing. I'm just looking for my water. But, and then I just couldn't believe that this was a type of healthcare provided free of charge in this province, like paid through by tax dollars, that was regulated, insured, and I could have my baby at home or in the hospital. At the time that I was pregnant, there were no birthing centers that I could access where I lived. Just a little pause while I take a drink. So from that experience, I just thought, wouldn't it be magical? Such a change. Like, I felt empowered, and it wasn't that the midwives empowered me. They facilitated an environment where I was actively engaged in my care, in myself. And this is something I have never experienced from a healthcare provider. And actually since that time. So when I decided then, well, I was already, when you finish your degree, what do you do, right? So, and I didn't really have an idea. So I thought, well, I guess we apply to medical school now, right? That's what we do. But I thought, well, I'll apply to midwifery, and I'll apply once though, and if I get accepted, that's a sign from, the creator, you should be a midwife. So that's what I did. I applied and I got accepted, and I was like, what? So off to Hamilton we go for midwifery school, and about maybe 1 or 2 years into the 4-year program, I realized that midwives couldn't work on reserves because that's federal lands. And that's when I was like, what? So I just had, whereas if I was a physician or a nurse, I could have worked on reserve. And I just thought, I just did this and moved my family, and I can't even work in my own communities. What? And I was truly, it was heartbreaking. And that's when I'm like, well, we have to figure this out. And I have to tell you that it seemed like the most obvious, like to the older white midwives who were teaching me, that they knew this. And I'm like, well, why is this acceptable? Like in my brain, I was thinking, don't you want to do something about this? Because midwifery is such a, it's a gold standard of maternity care in the world. And in fact, most countries have midwives. Why are we accepting less than excellence in our healthcare system, especially for our own people as Indigenous peoples? And so I became a midwife. That's where it's at. And then I really couldn't figure out how to work in my community. This was many years ago. Like, I graduated in 2005, so it's quite a time ago. But it was almost impossible to find a midwifery practice that provided services to Indigenous people. We're still a lot of midwives. I think most of them live in Toronto. And of course, there's lots of Indigenous people in urban settings, but I wanted to live in the North. That didn't work out for me. And neither did the way midwifery's practice worked out for me. So what I ended up doing was then decided to investigate, why can't we? This mysterious policy that the government of Canada has, that it's just the way it is, that we evacuate as a country women from rural and remote reserves constantly, all the time, to receive care in southern urban tertiary care centers. How is this normal? How is this an appropriate use of resources? Why are we centralizing healthcare services, especially maternity care services, in cities? What about smaller cities? What about level 1, level 2 hospitals? Why are we not allowing or facilitating the delivery of maternity care services by not just OBs, but by family doctors, by nurse practitioners, and by midwives? I had a lot of questions, I still do, about what is preventing Indigenous peoples from receiving the best healthcare possible, when they want it and where they want it, and by who they want to have delivering their healthcare services. And that really is what drives me, all because I myself had a baby. It just started questions, right? It's like, when you know that, it's like, well, why do we? And I think there is the most important thing students can do, and in fact, everyone can do, is ask questions. And it might seem like a baby question, or like, well, that's too simple. It's sometimes the simplest questions that actually will result in really meaningful conversations. And it's like a puzzle. And I actually quite like some puzzles, not all of them. I get frustrated. But this is a puzzle to me that is about, it's more than me. And it's something that I want to, well, I have the capacity to continue to figure out, because I know 100% there are great students out there who want to make a change. There's great research being done to create change for equitable maternity care services. There are great clinicians trying their best to do something so that the system changes, but we need more than a few people. We need a mass amount so that there's a systems change. So I just keep talking about it. I teach it in my courses. And again, reminding students, ask the question that's important to you, because what you think matters, because you can see things from your perspective that's not working, that has become so normalized for people in the system. Like it should not be routine, for example, what's a good one? That we don't have more dialysis units in the community. Why do people have to live in an urban center to receive dialysis treatment, and then therefore live and move and leave their homelands, if you're Indigenous, leave their family and communities? And that's for everybody in this country. Why have we become so comfortable with having centralized healthcare services? Well, I have been. I mean, I've received one time when I was doing my doctoral research, I received a phone call from one of the nurses who worked for the federal government, and told me that my research was a mistake, that I was making an issue out of nothing, and that for my own reputation, I should actually change my research topic because I was wrong. So she basically spent an hour threatening me. That was not fun. And, people saying there's no such thing, I'm making it up, but I can actually see people being evacuated for birth. Like I work at Kingston, I can see Inuit walking around pregnant, waiting to go into labor, have their baby so they can go home. But I don't understand why we can't just face the possibility that what I am saying, what I've written, that what people have shared with me is a truth, and that the healthcare system, the maternity care system, isn't working. And I don't know why people are so hesitant for change. And I think it might be just this, they'll look bad. Well, you look bad already. By not changing it, you're kind of looking worse, because you're just, and I don't know, I think it takes quite a huge amount of courage and emotional strength to see that something's not working, and that something might be something that you're perpetuating. I think we need to be aware that these conversations can be very emotive, and people generally don't like to be told by a midwife that they're wrong, especially an Indigenous midwife. I think they're wrong. I think we have a huge issue. All the literature about maternity care crisis in this country points to a substantial problem that we have, but we just keep going as if we run faster, it's going to get better. And that's not true at all. We're going to end up with burnt out healthcare providers, or healthcare providers who are providing care that they know is suboptimal. We need to support healthcare providers. We need the system to work for everyone. And I fear that this non-engagement is just going to lead to something catastrophic. I don't know how many more inquests we need before we understand the underlying racism against Indigenous peoples and anyone who doesn't fit these categories of wellness. Like it's somehow a moral issue instead of a healthcare issue, or a social issue, or structural issue. So we need more thinking, but sometimes people are so busy they don't have the time. So again, I feel like I don't have a solution. And the cool thing is I don't think I need to, because this isn't about what I think. This is about working in a system, problem solving for something. But we do need leadership to tell us to change and to make us change, because without that, things are going to remain the same. And against recognizing the huge power and authority that medical associations have, and their legal resources available such that they don't have to change or even admit wrongdoing.
Mm-hmm.
It's how have we come to this point where we can't even quickly see a solution?
This is just part 1 of a 3-part series interviewing Dr. Karen Lawford. In the next 2 episodes, we're going to be looking more at her research regarding birth evacuation, as well as what the healthcare system can do to be more inclusive towards the needs of Indigenous women. So subscribe to our blog, follow our Instagram, and stay tuned for next week.